help me connect.
So if you do the share screen and just click it, and then
Here.
you got the presentation.
Oh, perfect. Okay.
And then you won't even have to see your face.
Perfect. Unlike the one the other day. All right, where's view screen? Oh, full screen mode. There we go. Okay. I just wish there was a way to get rid of that, but maybe not.
That thing. So okay, with that here, you can't. I touch this.
Not at all.
I believe you. Oh. You can move it.
Oh, perfect. Okay. Yeah.
I don't know if that's not
That-
why.
That should work. So I don't want to hit mute. I don't want to hit mute.
I know, that's what I was like, there's no way to press it. And this, I would just press that down size.
Okay.
And then you can move that too, I believe, if you just press the top.
Put that up there. Okay, good.
I found that out right after.
Yeah. All right. So you tell me whenever you're ready, and we'll give maybe everybody another minute or two. Might just like lower them a little bit. Is that okay with you? You lower really? Are you okay with that?
I usually.
Yeah. And I think you can see a little bit better.
Oh, we can also pull down that screen too. That helps it all.
You guys tell me, can you see that okay?
Okay. It looks good to me.
Okay, so I'm Erin. Nice to meet you. This presentation is actually based on a program that we have through Cleveland Clinic called Moving Smarter. And it's like a physical therapy nutrition program for patients who have been diagnosed with osteoarthritis. So the presentation is based on that program. It kind of hones in on knee OA. So if knee OA isn't your thing, that's okay. Just kind of relate it to all of any, shoulder, hips, ankle, whatever. So yeah, we'll go through kind of our programs designed for patients who are actually referred to PT with a diagnosis of osteoarthritis. And if you ever choose to do this again, it's in like an online. You would just sign up through your calendar on Cleveland Clinic. And I can show you that. It's the events calendar on Cleveland Clinic. All right, so with the Moving Smarter program, we're going to talk about what osteoarthritis is, what are the causes of osteoarthritis, common symptoms, risk factors, and then mechanical and rehabilitation interventions. So this is our nice knee joint here. Again, really heavy on the knee, but relate it to whatever joint might be bothering you. The knee is the largest joint in your body. So you have your femur bone up here at the top. You have your kneecap, also known as your patella, right here. And then your leg bone, which is your tibia. And then on the side, which they didn't include, is your fibula. So inside that joint, you have this nice cartilage, this white area right here that acts as a cushion and a gliding surface for when your knee moves. And it keeps the bones from rubbing together, right? So you hear about that bone on bone. That's what we're talking about when cartilage deteriorates. And then you have your ligaments on the side and in the joint here. It provides extra support for the knee during activities. It's basically stability for the knee. Okay, so osteoarthritis is the most common form of degenerative joint disease. Leading cause of disability in people over 50, tends to affect most load-bearing joints. So knees, hips, I see ankles, shoulders too, although that's not like a huge load-bearing joint, but we do see a lot of arthritic shoulders. And then the osteoarthritic process is very gradual. So you might be experiencing symptoms that last for a couple of years that you're able to manage, or it'll be a quick onset with quick degeneration. It just kind of depends on where you're at. So the two primary processes are the cartilage breakdown, so that nice smooth area that helps glide the bone. And then small deposits of bone can develop called osteophytes or bone spurs. And then those can sometimes grow on the edges of the joint. So here, again, this like nice smooth cartilage on the left. This is a knee that is going to move very well. And then on the right is where you have that cartilage that begins to break down. A lot of times we see meniscal issues with this. So that meniscus is like a little cushion disc that provides extra shock absorption in here. And when we have osteoarthritic knees, a lot of times degenerative changes happen to the meniscus as well. Okay, so risk factors, advanced age and excess weight and obesity are probably our top two, and then joint trauma and family history. So advanced age, we do see knee osteoarthritis increase at the age of 45 and beyond. You know, there's always these outliers where you have people in their late 30s or late 40s, and it increases with age. So the basic wear and tear, that cartilage thins and becomes less flexible, making you more prone to that osteoarthritis. Second one is excess weight and obesity. So knees are weight-bearing joints, and a person who is overweight or obese is significantly more likely to develop knee osteoarthritis. So 2 out of 3 people who are obese are likely to develop that, and then losing even a few pounds can significantly reduce the risk. Joint trauma, so we do see patients who've had severe trauma, car accidents, athletes with, you know, sport type activities or sport type traumas, broken bones, meniscal tears, things like that. They can cause damage to the knee joint that eventually leads to knee osteoarthritis. An osteoarthritis that develops as a result of a previous injury is termed post-traumatic arthritis. And then family history. So similar to height and hair color, you know, our osteoarthritis can be influenced by genetics. So, you know, mom and dad had it, brothers had surgery, you know, things like that. We see not like all the time, but a good amount of the time. So symptoms of osteoarthritis: knee pain, knee stiffness, inactivity can oftentimes make it worse, and then knee swelling. So, you know, most of the time we hear knee pain. That's probably the most commonly reported symptom. The description of the pain will depend on the situation that you're in. A lot of times I hear like a deep, achy toothache type pain, but it can be dull or sharp, dependent on activity level. So, you know, you hear it hurts when I go up the stairs, it hurts when I go down the stairs, it hurts when I get up from a chair, and the pain can decrease with rest and ice. Second is stiffness. So with stiffness, that bone friction and swelling in the knee joint, you're not going to move as well, right? So experiencing only knee stiffness in the morning or after sitting for long periods of time, and its stiffness may or may not be accompanied by swelling. But most of the time we see a lot of knee range of motion that's more limited. So a lot of times a person with advanced knee arthritis, they might have a hard time getting that full extension. So getting that leg nice and straight. They might be sitting here. And then inactivity makes it worse. So stiff after sleeping or sitting for long periods of time. So our goal as physical therapists is to keep you moving. And then knee swelling. So when knee cartilage wears away, bones can rub together, resulting in irritation and ultimately swelling, which is basically fluid in that knee joint. It can be accompanied by a sensation of warmth, and then sometimes people can say like it burns. So diagnosing osteoarthritis, most individuals over the age of 50 will have signs of osteoarthritis in their major joints that can be seen on an x-ray, but most will have no symptoms. There's no single test that can definitively diagnose osteoarthritis, but our docs typically use like a comprehensive approach. So your x-rays, your medical history, and then a physical exam. So on the left, you can see this is a right knee. So this is the outside of the right knee. This is your lateral joint space, nice open area here, and then the medial joint space, nice open area here. Whereas a knee with osteoarthritis on the right here still has a good amount of like lateral joint space here, but on the medial line is losing that joint space. So not quite bone on bone, but definitely getting very close. So as physical therapists, our goals of treatment are to control your pain, improve your joint function, help you maintain a normal body weight through exercise, and then achieve a healthy lifestyle. This is just a little true or false. So a lot of times patients think exercise will aggravate your joint pain and stiffness. You know, really, we want to help strengthen the muscles that surround that joint, so it takes a little pressure off the joint. So there might be some exercises that don't feel great on your knee joint, but our goal is to find the ones that do feel good and help you long term. And I think I talked about this on Monday, like most times people aren't like wanting to run on a treadmill. And like our goal for you is not to run on a treadmill unless you really wanted to. But working on those strengthening those muscles, and then like swimming is really good, cycling is really good, things like that. Lack of exercise actually makes your joints even more painful and stiff. So we talked about this, inactivity is harmful and can ultimately lead to other health problems. And then keeping muscles strong is crucial to maintaining support for your bones, which is also true. Okay, so our treatment interventions as physical therapists are to develop a graduated and targeted joint, not just knee, joint strengthening and stretching program for you to continue to do independently. Just to go over some benefits of exercise. So not just improving your strength, but your heart and lung efficiency, reducing your blood pressure, weight loss, improving your sleep quality, reducing risk factors of other illnesses, improving posture, and reducing additional injuries. And this is kind of what we hear from people why they don't exercise. So they're too young, too old, too busy, too tired. And a lot of times they think they're in pretty good shape. So before you even see us, most times we get the referral from your doctor who have evaluated you, maybe have done x-rays, done that exam to figure out what exactly is going on and to make sure that you're appropriate for physical therapy intervention. So, you know, our bread and butter is exercise. So we want to make sure that you're healthy enough to be able to exercise with us. And we really just want you to choose activities you enjoy, set realistic goals for you, tailor your program to your fitness level, you know, give it a little time, build rest days into your schedule, and then listen to your body. Down here, says the human body is designed to adapt. Okay, so different component parts of fitness. You're going to have your cardiopulmonary endurance, your muscle strength, muscle endurance, and then flexibility. And we talked about this the other day. The only thing that they're missing is balance. So cardiopulmonary endurance, improving heart health and activity tolerance. Muscular strength, being the ability to exert force for a short period of time. Muscular endurance being ability to perform exercises multiple times. And then flexibility, which is the ability to move the joint through the full range. So ideally, when we're developing a fitness plan for you, we want to make sure we're including some sort of warm-up, flexibility component, a cardiovascular endurance component, and then a strength component. And these are just kind of the guidelines of times and how many days of the week that you should be focusing on this. You know, almost muscular strength, I would think you would be more than twice a week. I probably would suggest 3 at least. At minimum, yeah. Right. And really, I think a lot of this is changing. Like have always been so like cardio focused and cardio heavy, and we're finding more like, especially, this is totally off topic, but osteopenic women who are older, like we need weight bearing, strengthening exercise. We need the muscular strength rather than the cardiovascular endurance, which is still important, but I would say like kind of gearing towards that muscular strength a little bit more.
Can you do the muscle? Would it be considered in the muscular strength category?
Yes, yeah, we'll get to that in a second. Bands, machines, free weights, body weight, like it's kind of wide open. Yep, absolutely. So this is just a reminder that stretching is not warming up. So warming up, we want you to do that first before you go into your strengthening program. So a lot of times in physical therapy, we'll have patients get on like a new step or a bicycle, elliptical, sometimes the treadmill for 5 or 10 minutes just to get the blood flowing before we go right into the free weights or the machines or anything like that. And we always suggest stretching after, like your long load, long duration stretches after. So cardiovascular activity level, they suggest, 4 to 5 times a week, 20 to 30 minutes. Walking is a great place to start. But again, do what you like. Swimming, getting on a bicycle, walking, elliptical, whatever you feel like you can be compliant with. And then making sure you can carry on a basic level of conversation without being too winded. But again, if you can easily sing a song, you're not working hard enough. And then types of strength training. So as therapists, we do isometric versus isotonic. Isometric being more so like tightening the muscle or contracting the muscle without joint movement, whereas you're probably going to be more familiar with isotonic exercises. So that's where you get your bands, your weight machines, your free weights, and body weight. And then here's balance. So all components of exercise should improve balance, but we were talking the other day, like it would be good to have like 1 or 2 balance exercises that are kind of a go-to for you. What do you say? You say you give patients like a 4?
Yeah, I would suggest like 4 things to focus on for balance, like not specific exercises, but like concepts.
Yeah.
So a single leg something.
Yes.
And so, I mean, my favorite real quick, I'll tell you, is just like a mini lunge and reach. I like hold the ball and I just have people step forward and just tap the chair and just kind of go back and forth. And then as you get stronger, you can step back a little bit further. Because when you go to fall, you kind of plant all your weight on one foot. So it almost like brain accent. So I do like a single leg, an ankle strengthening. So like the alphabet or cat raises or things like that. And then a static balance, something where you're standing still, like a single leg stance, and a dynamic, something where you're like tandem walking, like heel to toe or something like that. But those 4 components, in my opinion, are like the 4 things that you should hit if you're really trying to focus on
balance. Yeah. And here's my thing: if you're time constricted, just work on a single leg balance, brushing your teeth. That's it. Every day. Nice and easy. Yeah, I do it. I do it when I'm brushing my teeth because our balance just doesn't get better as we age. It is what it is. So the more we can work on that, the safer you are as you age. And if you do decide to go get a total joint replacement down the road, balance is going to be huge for you because essentially you're not walking the same way you have been. You're using a new assistive device. So if you can kind of pre-work on that balance, yeah, you're really setting yourself up for success. Okay, so things that you kind of want to watch, like exercise shouldn't make you miserable for days on end, right? Like this soreness should last a day or two and then go away. So if you're doing activities where you're feeling like you can't get out of bed for 5 days, not the activity for you, okay? Yeah, so again, like a day or two, but should that reactive sort of pain should calm down within 48 hours. And then you can always modify activities. So certain high impact activities should be avoided. Again, like, we're not really telling patients a whole lot to go run on a treadmill or jog. That's a lot on a weight bearing joint. But you could get into our pool here and do some like water running if you're like a diehard runner. Or I think we were talking about the other day, are you a member here? Or like our pool classes are awesome. I used to work at the Nat and they're so good. I mean, I don't know what the Nat is now, but like the variety of pool classes we have here. Oh, okay. Yeah.
Me, I always tease the other people. To me.
Yeah. My gosh. Yeah, we're so lucky to have those at like all the health and wellness locations. So, all right. And then again, I won't harp on this too much, but patients want to watch their weight. So for every extra pound on the body, an extra 3 pounds of pressure is exerted on weight bearing joints. So gaining 10 pounds can mean an extra 30 pounds of pressure on that weight bearing joint. And I think like you guys have had the dietitian talk to you. So, maintaining a healthy weight, I'm sure she talked about, whatever nutrition wise. So, we won't go too much into that. But why exercise works. So if your activity stays the same and your intake stays the same, eventually you'll gain weight as you age because your metabolism is slow. So exercise increases your metabolism. Muscle uses more calories than fat does. And then metabolism slows as we age, primarily due to a decrease of muscle tissue. And then after 30, which is so sad because it's so young, the body gradually loses muscle. So a good combination of diet and exercise. Seek professional help, which you guys are all doing in your weight loss plan. Okay, so mechanical treatments that we can offer through therapy. We do have some orthopedic products that can be used to help stabilize or take pressure off of the knee. A lot of times we see with knee osteoarthritis, a bow-legged position. So you have a lot of space in the midline here. And then we also see like a knocked knee position, which is more so those knees coming in, creating an L. We call that valgus. So the easiest thing to start with is a shoe insert. That can help lessen the pressure put on the knee joint when walking. There's anything from like a heel lift to a custom shoe orthotic. We kind of have a whole span of things. So, if your therapist thinks then heel lift is appropriate for you, we can just give you one. I usually have people try off the shelf orthotics first because they're much cheaper than custom orthotics typically. But we do have somebody here who does the custom shoe orthotics. Yeah, if you get good coverage through your insurance, those are the best to have because it's scanned for your foot and your foot's needs. We do also offer unloader braces. They alter alignment of the knee during stages of walking to decrease pain. There are these big braces that you see football players wearing. I'll show you in the next slide. It stabilizes the knee and can provide pressure in a direction to decrease pressure on painful areas. So they look like this. I was telling the group on Monday, the compliancy with the unloader braces are kind of, most people don't want a huge brace when they're working out. They tend to get in the way a little bit. Some people love them, some people don't. So that's probably the biggest brace that we have. This is just an x-ray of the brace on and how it can shift. So you see here, that's what we consider bone on bone right there. The unloader brace is put on here, and you can kind of see how it shifts that knee a little bit and kind of open up a little bit of joint space here. I would say we see these braces a lot. These are just like a knee support brace. It's a low profile unloader. It definitely works to help decrease front-sided knee pain. It stabilizes that kneecap. Patients do like this. Again, this is all rubber here, this like spider web looking thing. So it's a little big too, especially like if you're putting it on to walk or just go about your daily activity. And then sometimes we just recommend like a compression sleeve if you're having a lot of swelling. This neuromuscular stimulation this is actually a brace that a company can provide if you're having a lot of trouble with your quad strength. It actually has a built-in like a electrical stim unit that provides stimulation to that quadricep muscle to help tighten it while you're doing the exercise. It's used a lot of times with patients who've had ACL repairs, reconstructions. I will say I haven't seen a patient with knee OA who's had it, but we do have it out there if needed. And then this is the brace opened up, and then it has a little app to it, and you can kind of adjust to what you need. Any questions?
I know this is geared towards the knee.
Yeah.
And it looks like some of those will help, like where you had the one where it was bone on bone and then the brace.
Yeah, this one.
Do they have anything like that for hands?
I am sure they do. Physical therapists typically don't do a lot of hands. Our OTs are the hand specialists, but I can ask them. Actually, I can go right out there.
Years ago, years ago, so many of my colleagues would have all kinds of things with our hands and the wrists. So I thought, I would just sit around and wait for this to hit me. Why don't I go and talk to them? And he made me braces that fitted to me, and he suggested to wear them at night.
Yeah.
So I had that, and then he made stuff like my gloves, which were wet around.
Right.
But now, in the last few years, I've looked and I said, oh man, I'm really starting to get some of the things. I wonder if I should quickly get into those again. It probably won't reverse it,
But
it
it'll
may
help.
save it.
Yeah, you know what? Can you give me a minute? They're right across the hallway. So if one of them's free, I'm just gonna ask.
I just don't buy the hands. It is the day of specialization.
Oh, yeah, sure.
And that's good. You can't know everything about everything, so.
Yeah, it's better to have someone that, see something regularly than just trying to guess in a broad spectrum of it.
Right.
And it's definitely not.
It's a tough one.
Yeah,
It's a tough one.
there's so many like fine tuning things going on.
Yeah. But these, my goodness, I can think so many friends, things.
Oh, yeah.
And then I know in some of the bar fests, she'll try to do something new and I'll be finding. And I overextend myself on that. And then as she said, I'll be aware of it that it stay and then it goes away. So that's good.
Yeah.
Keep working to try to strengthen it so you don't.
Absolutely.
But if you never felt anything, that would tell me I'm not working the muscles right.
Yeah, so ideally there's like what's called stimulus to fatigue ratio.
Yes.
So you want to provide as much stimulus with as little fatigue.
Yes.
And so usually as you get close to failure, the fatigue level accumulates a bunch.
Yeah.
So it's like you want to find
Happy medium.
Yeah.
Not too easy.
Yeah, so you want to feel it, but yeah.
So there's one for the thumb.
Yeah.
But there's not anything for like.
And I have a flat one, that because it's the base word. Okay, yeah, so, because I noticed my thumbs are getting crooked and my mother had a lot. So,
Yeah, my mother-in-law actually just went through that surgery. Had like a tendon.
or joint where they take the tendon.
Yes. Yeah. So far, so good. Hold on, let me click out of this. She is headed at the last week of September 25th. So she is, yes. She's doing pretty well. So she is currently in like a hard kind of cut like this, but like down. And she's supposed to see the surgeon next week, and then he might take her into like a more softer brace and then have her come out of the brace that she thinks, but she's doing OT like every other week. But yeah, she's had,
Go out to Crystal Clinic.
she just does everything at Crystal Clinic. Yeah, she has had 2 knees, foot, hand. She hasn't had a shoulder.
It's gonna be really good.
She's gonna be just fine. So yeah, I think the biggest thing is just like watching here for the tendon transfer.
Yeah.
You know.
Yes.
But yeah.
Suggested I gave the course back, and then it was that very day, I happened to leave after my go to the grocery, and there was the nurse at the time.
Oh,
And